I'll call upon the first speaker. We are in the session is that golden words for the pediatric ophthalmology. So we have the first speaker, Professor Rohit Saxena from RPC. He'll be talking about preventing the incidence and the progression of childhood myopia. So, Rohit?
Yeah, I'm here. I'm just checking there.
And since we are running short of time for the next session, because we got the hall late, so I'll ask the second speaker if he's there. Dr. Deepthi, are you there?
Deepthi has a talk somewhere else, she told me, so she'll come in a bit.
So we can take, Dr. Ma'am is also not there.
Yes, so we can
Dr.
take
Amit is there?
Amit is here. I think I saw Amit. He also may have gone for a bit, so.
Deepthi has two talks in this session, so we'll have to wait a little.
ठीक है, कोई बात नहीं. Pointer है क्या? चलो pointer नहीं. Start? Yeah. Okay, thank you to the organizers for giving me the opportunity and for us to discuss on this rather important topic. I'll be talking about preventing progression in childhood myopia, and everything that I'm going to speak on is related to or is actually concised in this excellent consensus guidelines that were released by AIOS. So if by chance you wish to follow up on what has been talked about, you can check this up. This is, I think, available on the AIOS website also. So thank you again. The most important question that we need to ask is why to intervene, and over the last decade and now, I think this question has become a wee bit redundant, especially in 2016 when this paper from Brian Holden came, which has predicted that 50% of the world's population is going to be myopic. When we actually analyzed the data set in that paper, we realized that India had been given a miss, because according to them, there was not enough data of good, well done surveys or studies from India, and therefore really the Indian 1/6 or more now of the population was kind of aggregated based on data available from Nepal, Bangladesh and nearby states. We actually did a systemic review and meta-analysis of all the data available in India, and over the last 4 decades, and based on that we came to a crude prevalence of 7.5%. And the most startling thing we actually found was, and unfortunately this data is pre-COVID, so we don't know the impact of COVID, while we all agree that probably it's going to accelerate the progression of myopia. The other important thing that we realized was the significant increase in the last decade in rural children. So while we used to think that rural areas are rather safe, but just in the last decade it has apparently increased from 4.6 to 6.8 based on the data sets that we have in the various parts of India. So when would we intervene? Our decision should be based on the risk factor identification. So each child falls into a basic risk factor group, which is dependent upon the baseline refractive error, the magnitude of myopia that he is diagnosed with the moment he presents to us, the age of onset of the refractive error. So the younger the child is, the more years he has for progressive myopia, and he's going to land up at a higher level of myopia by the time he levels off, and therefore your decision to intervene and the rate at which you are, how aggressive you are, is going to be accordingly tapered. Genetics or the parental refractive error, the family influence, both parents, if they are myopic, have a 3 times risk of progressive myopia in a child, and of course the visual environmental considerations. The other most important thing we feel is that you must document myopic progression of at least 0.5 diopters a year. You can not necessarily have to follow up the patient for a year. You may keep a record of, evaluate the record of the previous glasses, the power of glasses. The only downside of that is that sometimes, unfortunately, many ophthalmologists undercorrect the first time a patient is prescribed glasses, which there is no evidence to say that undercorrecting refractive error will at any time reduce the rate of progression or in any way is beneficial to the child. So you identify a child of myopia, give optimal glasses. Do not undercorrect, of course, never overcorrect a myope, but definitely at the moment there is no evidence to say that you should undercorrect. That way you'll be able to know what is the rate of progression of myopia and accordingly decide your interventions. Risk factors, the most important are the refractive errors and including the fact of pre-myopes. There is now a defined category called pre-myopia, which essentially means that their refractive error is a lower hyperopia than the age-matched normals. And for about a 6 or 7 year old child, it's about 0.75 diopters. So less hyperopia or myopic obviously becomes a myope, less hyperopia pre-myopic child. Younger age group I talked about, parental history, progressives, females for not so very clear reasons are at a higher risk for progression, and of course ethnicity, while Indians don't come into it, but East Asians definitely, so maybe we should be concerned about our northeastern regions. The other modifiable risk factors or environmental risk factors are the visual environment. Children who become myope are tending to spend less time outdoors, unfortunately accelerated by COVID. A lot of near work association is now being proved, reading at very close distances and continuous periods of time. The other important thing being highlighted now is the anomalies in binocular vision and accommodative lag. So esophorias, accommodative lag at near, and reduced accommodative facility. And of course, not so clear inconsistent association with other attributes. Preventing the onset, identify the pre-myope child. We talked about low hyperopia, a genetic history, spends less time outdoors, increased near activity, has some form of binocular vision disorders. At the moment, at least in India, there is no evidence that you should pharmacologically or optically intervene. However, you need to educate the parents and the child. Risk factor modulation, try and reduce the near work, give breaks, encourage outdoor activity. So these are the interventions we would recommend for a pre-myope. It's important to discuss this with the child and the parents, particularly how to reduce the environmental risk factor the child is in. The moment you identify or you consider myopia or consider myopia interventions, do an age-appropriate cycloplegic refraction. You can use an AR also. Objective retinoscopy, at least at the baseline, is useful. Prescribed glasses, do not undercorrect, as I talked about. Document the glasses because it will help us to document the rate of progression of the child. Now, axial length measurements, irrespective of the way you are measuring, whether it's ultrasound or optical, most of us have optical biometers with us, so an optical biometer would be very, very useful, because finally axial length is what you need to prevent progression, and that is where your intervention should be. Binocular vision, ocular surface health, if you're looking at intervening by ortho-K or soft contact lenses, pupillometry or the size of the pupil, because atropine may make that small difference, and of course fundus if there is myopia. You have a lot of optical interventions. There is no evidence that single vision glasses make a difference, but anyway, that is something that all children deserve to have. We have now what are called peripheral ad lenses, which reduce the peripheral hyperopic defocus. They are optimally corrected for the central foveal area, but peripherally they are bringing about a myopic defocus as compared to a peripheral hyperopic defocus, which is thought to be the cause for progressive myopia in these children. The next important thing is, of course, to look for accommodative lag, because these children would require an ad or a near vision glass along with the distance correction. So that's another important aspect that you need to identify and measure. There is evidence now that bifocal prismatic ad lenses can significantly reduce progressive myopia versus single vision lenses in children who have accommodative lags. Soft multifocal lenses were perhaps the first thing actually that got FDA approval for management of myopia, and Cooper Vision MeSight were the first ones, no financial interest. They have been found to be definitely helpful. Ortho-K, again, unfortunately, contact lenses are not very popular in India, but Ortho-K have been shown to reduce progression by almost 45 to 50%, besides, of course, keeping the child spectacle free during the daytime. We are all aware of the pharmacological interventions. Atropine is the most common, most popular. There is now hard evidence that 0.01 reduces the progression. There is now growing evidence that 0.05 may be a better cutoff based on the effect of preventing myopia progression and the side effects. But of course, there is an ongoing study, multicentric trial in India on 0.05, so we hope we'll get better data and be able to decide which percentage is better for Indian children. Finally, deciding options, very small children, make sure it's progressive. It may just be part of their congenital myopia or part of ROP or a preterm birth. Low myopes may be part of emetropization and may not require intervention. 6 to 11 years is our key area of intervention, because after 12 to 13 years, although again this knowledge is changing, we expect their progression to actually level off on their own. So again, the other rest of the things I've talked about, ocular surface, binocular status, and of course identify genetic factors. Atropine, treat for at least 2 years, then taper, do not sudden stop. Contact lenses, look for financial aspect. Of course, the parents and the child should agree. Both ortho K and soft contact lenses need monitoring even after you've stopped, because there has been a rebound effect or the wearing out of the preventive effect of optical interventions. And of course, for children who are very rapid progressors or continue to show progression in one form or the other, there is evidence that combination therapy may be much better. You assess outcomes at least 6 months, because before that you cannot know whether your impact is effective or not, and based on that you decide whether you want to switch or you want to augment interventions. But sometimes it may take up to a year, so it's not a very short-term intervention that you can decide on. Treatment may be stopped or switched depending upon your rate of progression, tolerance, compliance, and of course cost features. So this is just finally a chart showing the various impact of the various interventions that we have. You can see everything works, but the most important thing is all children, all parents need to be informed about the impact of environmental modification, outdoor activity. Of course, soft contact lenses, ortho K work, not so popular in India, and of course atropine, low dose atropine drops are definitely effective. Thank you very much for the opportunity.
Thank you, Dr. Rohit. I'd just like to, sorry.
I'm sorry? So if you are having once a day, usually you are giving the therapy once a day at night. You can go to alternate day for a month or 2 months. Then you move to weekend. Then you need to go to once a week, and after that you can stop and then follow up after 3 months. So you have a 6-month period in which you can actually see is the child rebounding, is the rate now picked up again or not. So you remeasure for the change of refractive error.
Is Dr. Deepti there? No. Dr. Rohit?
Dr. Amit has come, so maybe he can.
Yeah, Dr. Amit.
Yeah.
Dr. Amit, you can take your, in the meantime, Dr. Rohit, just small, yeah, sure, go ahead. Yeah, that's what I was about to.
So unfortunately, there is no hard evidence. There is a group which says that if there is evidence of peripheral hyperopic defocus, they would be the best. But evidence has shown that there are only 30% or 40% children who actually have proven peripheral hyperopic defocus, as compared to results of studies on these lenses showing 70 to 80% effectivity in children. So I would say that currently there is no hard evidence to choose either or. Of course, if there is sometimes parents are not willing for pharmacological therapy, or there is children who start on topical drops have glare, have near vision problems. In those conditions, it's definitely beneficial. Parents who are unwilling to start a drop. Otherwise, really there is no hard and fast rule to decide whether you want to take optical. Opticals are very expensive. They are anywhere between 12 to 16,000 rupees a pair of glasses. And that no child is going to just keep one pair of glass. And of course, within a year, the change of refractive error may occur. So that is why cost is a major factor. But otherwise, at the moment, there's nothing very clear to differentiate. You have contraindications for not using one form or the other, but definitely for contact lenses, but not so much for optical versus. And now they're very easily available, so availability is also not a cost.
There have not been much studies of using combination therapies, as in pharmacological plus the spectacles, or pharmacological plus the orthokeratology, both at the same
True,
time.
actually, because we are still establishing the place of individual. But yeah, with contact lenses and atropine, there are a couple of studies which have shown that both of them, because they probably work by different routes, have an additive effect. But of course, you not start both in the same go in the first time in a patient. You want to actually evaluate the impact of either on the rate of progression, and then probably move on to augment. Thank you.
Yeah, Dr. Amit? Yeah. So Dr. Amit will be talking about capsule management pediatric cataracts.
कनेक्टर रहेगा C-type, C-type.
Good afternoon. Sorry for the delay. Uh, my talk is about capsular management in pediatric cataract. As you all know, pediatric eye is a growing eye, so 2-3 issues, especially in management of capsule, visual axis opacification, IOL power calculation. So I will be mainly dealing with how to deal with anterior capsule as well as posterior capsule, and what are the options that has been used in literature. So due to elasticity of capsule, there is chances of peripheral extension, and due to low scalar rigidity, one should suture the port, main port as well as side port. It depends on age of the patient. Younger the age, one should suture all the port. And due to vitreous upthrust, one should use high viscosity viscoelastic, and one has to go for deeper plane of anesthesia to contract the upthrust. And for instrumentation, a good quality vitractor, coaxial forceps, coaxial seizure is required. Capsular staining is not required just for visualization. It has been found that elasticity of the capsule is decreased after staining. So one should stain the capsule even if there is immature type of cataract or clear areas. So coming to anterior capsulotomy, up to age of 1 to 6 years, it has been found that one can go by forceps or vitractor. It depends on personal choice, and again one should go for undersizing. Size of capsule, when you compare it by adult capsular axis, if you go for normal sizing, you will oversize. So always go for undersizing. So it depends on personal choice whether one can go for simple utrata or coaxial forceps, and always there should be centripetal force. At this stage, it was going outward, so I used coaxial to again pull inward to complete the rhexis. One technique, push and pull technique, has been described in literature. In this, two nick has been given on opposite side in the mid peripheral area, and one side is pushed and another side is pulled to make circular axis. Posted stamp multiple capsulotomy has been described by Titial et al. In which 25 to 30 nick has been given to contract the peripheral pores. So basically to prevent chances of anterior capsular phimosis. Again, 4 incision capsular axis. In this 1 to 2 millimeter size of 4 arcuate incision given in 4 quadrant, and inner part of the capsule is pulled to make a circular axis. Femtolaser femtosecond laser capsulorhexis has also been described by use of table mounted femtosecond laser. Even Jepto has been used for making capsulorhexis in pediatric cataract. It has been found in a long-term study, it has been found that under age of 6 years, one can go for betractor, one can use betractor. It is more predictable compared to manual capsulorhexis. In fibrosed capsule, it is very difficult to go initially pierce the capsule. So in that cases, one can use two cystosome to initially puncture, then one can decompress, and then one can use betractor. Sometimes betractor doesn't work, then you have to go for multiple nick by the coaxial seizure, and then one can enlarge the capsulorhexis. Coming to the posterior capsule management, again in posterior capsule management, as posterior capsule is almost 3 to 5 times thinner compared to anterior capsule, so it is very difficult to grasp. So don't go for overfill, and after initial nick, one should inject some viscoelastic to separate it from the anterior hyaloid face, and then one can use coaxial forceps. Again on the same principle, grasp and regrasp, and force should be always be centripetal. Just 1 minute. One can go for, after implanting the lens, one can go for posterior vitrectosis. That is more predictable, and less than 1 year of age, it has been found that it gives comparative result. So after vitrectomy, one can enlarge as per convenience, so that visual access should be clear. In one study, optic capture, one can go for posterior optic capture without vitrectomy. It has been found that chances of visual access or pacification is less when one can go for optic capture through posterior capsulorhexis. Bag in the lens implantation and lens in the bag implantation has also in lens in the bag implantation, basically both anterior and posterior capsulorhexis size is same, so that both anterior and posterior capsule margin it sticks, so it prevents migration of lens epithelial cells. Even pars placata posterior vitrectorhexis has been described by Basavda et al. In this, after implantation of IOL, first suture the main port, and then one can go for nicking the posterior capsule, and one can complete the posterior capsulorhexis. Again, it is more predictable compared to other technique. So to summarize, capsular management in pediatric cataract surgery determines the surgical strategy and site of IOL fixation. Deeper plane of general anesthesia is preferable to reduce vitreous upthrust. A stepwise understanding of capsular management results in good surgical outcome. Thank you very much.
Dr. Amit, I'll just make a note, I'll just make a comment in small regarding when you're doing, when you have to do specifically posterior optic capture, a vitrectomy is, you'll have to have a manual rhexis that time. And secondly, the gimbal technique, like my own thesis was on that. So what I found in my study at that time, at that almost 20, 25 years back, I found that for less than 2 years of children, if you're choosing, you may do without an anterior vitrectomy, because the children who were lesser than 2 years in my study, even with a optic capture, posterior optic capture, they specify their anterior visual space specified. So doing an anterior vitrectomy is becomes must for this. But above the age of 2, the visual axis of those children remain clear for a very long time, till almost 5 to 6 years of follow-up. The data
A study that has been published by, especially a study from PGI, Jagat
this is a
Rama's
recent study with Sabine.
Yeah, yeah.
Sabine also published a similar
In
study.
that study, basically they have compared with anterior vitrectomy without
versus no vitrectomy.
versus no vitrectomy. So it has been found that the study group in which anterior vitrectomy was not done, just posterior optic capture was done, chances of visual axis opacification was less.
No, so that's what I'm saying. See, in my study, what I found was, although in my time we were not using a foldable IOL, in that time we had a pharmacia John. That time these Equisoft lenses were not there. So that time also I found if the children were less than 2 years, there doing an anterior vitrectomy becomes a must, even with an optic capture. But after the age of 2 years, you can just go without doing an anterior vitrectomy. You can just go ahead and do an optic capture, posterior optic capture, and it works well.
And another important thing is basically vitrectomy is basically amount of vitrectomy. I have seen if anterior vitrectomy is less, so chances of visual axis opacification is more. So there's basically one should go for more vitrectomy compared to lesser vitrectomy.
See, as an anterior segment, when you're going through an anterior port, you'll be doing only an anterior vitrectomy. You can't do a port vitrectomy. That is not possible for an anterior.
And another thing is if parents are not following the postoperative protocol, especially they are not putting a steroid for as described, so then again chances of opacification is more, I have seen.
Steroid, obviously that inflammation is bound to be more in every pediatric cataract, especially if
when
you're
you
dealing
admit
with
patient
younger
for
age,
maybe 2-3 days, then it depends on parents, and if they are illiterate, they are not putting drop, then chances of again opacification is more. So that is why I was emphasizing that.
Thank you. The next speaker is Dr. Deepthi. She'll be first talking on prescribing classes.
No, first I'll finish off plication.
Oh, so you're talking on plication first? Okay, so she'll be talking first on plication procedure revisited, folds to strengthen.
Hello everyone. So the first topic of today is fold to strengthen the muscle plication. We all know that there are two basic strengthening procedures, and one is resection and the other one is plication. There have been multiple studies which have been done historically, and this do state there are multiple advantages of plication over resection, like there is no disinsertion, ciliary vessel sparing, less trauma, bleeding easier, and lesser operating time. Most importantly, it being reversible, especially within first 1 to 2 weeks after the surgery. Yet, somewhere over a period of time, in every pediatric ophthalmologist's life, we have seen that the plication has disappeared and the resection procedure has taken over the scenario. Why is it so? There have been multiple controversies which have been associated with the same. The first one is the bump effect. Many people think plicating the muscle may result in the bump, as shown in this photo, but why is it so? Historically, the procedure of the plication which was done, the muscle was basically folded anteriorly over itself, and that resulted in the bump phenomena without the central bites. The second controversy was the variable results. That could be two factors. It could be per se due to the strabismus. The second, majority of the time while plicating, people do plicate on either sides, but they forget to take the central bite, which in turn can result in some amount of the undercorrection, where people do postulate that resections result in better correction as compared to undercorrection with respect to plication. So hereby showing a video of about modified plication technique, where we do take the central reinforcement sutures, which result in taking care of both this bump as well as the undercorrection technique. So by using after marking where exactly the plication or where you had actually planned to do the resection of the muscle, that much amount of the millimeter marking once it is done on the muscle, by using a 6-0 bite, it can be the single suture or the double bite suture. We take bites on the either side, full thickness bite are taken, and the muscle is sutured over there. Once done, the suture is now passed exactly beside the attachment of the insertion of the muscle. Care to be taken, the sclera is very thin at the insertion. Some people do take it exactly just 1 millimeter ahead of the insertion, that is possible, that can be done too. Now this is the step where it actually differs from the older plication technique, where we go back and we take bite again through the muscle in between the two original suture techniques, and this is now attached exactly in the front of the muscle, passing through the episclera, and which in turn attaches the center part of the muscle also to the sclera, resulting in the central reinforcement. So when we fold the whole of the muscle to the center, there are two things: the muscle is totally folded upon itself and the muscle goes inside, the bump gets disappeared. Some people do place the iris repositor and pull the bump inside. The second thing is, because the whole of the muscle is brought in the front, similar to the resection technique, the chances of undercorrection is less. So it produces a comparable result as the resection as well as the plication now is producing comparable result. The same Parkes table which have been used for resection can be used for plication. That center bite just takes care of the bump effect. These are the immediate post-op. There is no bump which has been seen with this plication technique. Any gaze incompetence? No. In this modified technique of reinforcement technique, no gaze incompetence has been noted. There have been multiple modifications which the plication has undergone in the recent past. The one is the mini plication technique in all cases of small angle strabismus, where the patients do complain to us of diplopia. In those cases, a small 1 to 2 millimeter bite, about 3 to 4 millimeter from the insersion, only in the center. When it is that part of the muscle, it is attached to the center, and that results in tenting up of this small muscle belly to the center of the sclera, just ahead of the insertion. So we have done a small study over this, and just a mini plication can result in correction up to 6 to 8 millimeter, and if at all already the opposite muscle has been recessed, it can correct up to 8 to 10 millimeter, PD also. The adjustable plication technique, well, I have not tried it, but yes, it has also been documented. The adjustable plication techniques have also been done. The major limitations have been the tackling A and B pattern and the upshift bar, the downshift tackling of these two patterns. So with all these, I would like to tell is plication is now one of the emerging technique which is now used by all the strabismologists, and it gives as much comparable result and is a very good alternative to resection in any strabismus surgery. Thank you.
She has another talk. Would you like to come first, or she can carry again? She can carry the talk. So I invite even Dr. Navita ma'am for her talk on pediatric keratoconus management.
इस तरफ ओपीएल चल रहा था ना, ओपीएल में मैं भी उसमें था। आपका लंच हो गया? नहीं लंच भी कर लिया? हाँ जी। So I would be talking to you about management of pediatric keratoconus in children. इधर लगा, उधर आ तो जाए. So I'll be talking to you about management of pediatric keratoconus in children, and pediatric keratoconus should be diagnosed before adolescence. The management of ocular comorbidities has to be done like vernal catarrh, and there's accelerated progression, 88% as compared to adults. Significantly, it is more severe at diagnosis, 28% in stage 4 versus 7.8% in adults, and it affects the quality of life in children and adolescents. So there are many management challenges because of scarcity of functional complaints in the children, high accommodative power in children which compensates for distortions, and so the functional complaints, they come much later. The fact that there can be amblyopia, children are less compliant with the hard contact lens fitting, and corneal transplants in general carry a higher risk of graft rejection. So given these facts, it is important to counsel the children for not to do frequent eye rubbing, and also one has to manage the ocular comorbidities. Of course, diagnosis we all are aware of is very much similar to like that in adults. But it is important to know that ophthalmoscopic signs are more frequent in children. Asymmetry of the keratoconus is again more significant in children, and cones are more likely to be centrally located in the pediatric patients. So CXL may be more beneficial for children. Now, this is the treatment algorithm for management of keratoconus, which we published in British Journal of Ophthalmology. And collagen cross-linking is the way to go for cases that are progressing, because it increases the biomechanical resistance of the cornea. It should be done in cases where there is documented progression, but in case of children, I think we don't even need to wait for documentation of progression. Change in keratometry more than 1 diopter over 1 year, astigmatism more than 0.5 diopter over 1 year, and thinness pachymetry more than 20% over 1 year. Suffice it to say, in contraindications, that corneal thickness less than 350 micron should not be cross-linked, and so also the severe corneal scarring cases. There are currently 3 protocols which are used in children, and if we look at the various comparative studies as well as meta-analysis, both conventional and accelerated protocols are comparable. But it is the transepithelial cross-linking which gives suboptimal results. This is our publication on pediatric keratoconus, topographic, biomechanical, and aberrometric characteristics. And technique of accelerated collagen cross-linking is similar. We like to do this in children because it is faster, especially if the child can cooperate. And if the child cannot cooperate, then one has to use general anesthesia. So in these cases, epithelial debridement is done, followed by installation of isotonic riboflavin for 15 minutes, UVA exposure with riboflavin installation, which is done for 4 minutes, and then bandage contact lens is given. This is our study on 116 eyes with pediatric keratoconus, and as we can see, there are more males as compared to females, and more the age group between 10 to 16 years was the one which was most affected. Almost half of the cases were in stage 3 and stage 4, which means they were moderate to severe, and acute hydrops, it is important to note, was present in 8% of the patients. In 8% of the patients, and healed hydrops was present in 19%. That means, again, they were very severe. Non-progressive keratoconus was seen only in 1/3 of the cases, and half of the cases had progressive keratoconus. So this is just to show what we did in these eyes. Almost half of the eyes we could cross-link, and the other half of the eyes either were okay with spectacle or contact lens correction, or we had to do DALC or penetrating keratoplasty or even inject gas because they were so severe. So if you see the results after collagen cross-linking, the visual outcomes, they do become better, and this was significant. So does the topography, which is significant. Pachymetry does decrease, which is again expected, and which is significant. The aberrations do become better after collagen cross-linking. But there are problems with cross-linking in the form of sterile infiltrates, mild corneal haze, and infectious keratitis, which we saw in one eye. Progression we noted in 7 eyes out of 116, despite the fact that we had cross-linked them. And keratoplasty was required in 6 eyes, which means 6 to 7% of the cases or children may require keratoplasty. Acute hydrops, while we were following that, developed in 1 eye. So spectacle only cases also did well. These did not document progression, so they were not cross-linked in that study. Again, contact lens fitting, rose scale lenses was used, and there was significant improvement in the visual acuity. And the penetrating keratoplasty again showed significant improvement for severe cases, and so did DALC for these severe cases. This is just to show how intracameral C3F8 injection was done in one case, which was present in this cohort. So cross-linking halted progression in 80% of the eyes and improved BCVA, UCVA, and total higher order aberrations at the end of 1 year. Just to show a pentacam of a case where keratoconus pre-cross-linking and post-cross-linking, which has stabilized at 6 months. And this is another case with 54.5 diopters of astigmatism, which progressed by 1.6 diopters of astigmatism, despite the fact that we had cross-linked the case. And this may happen because if they do not stop eye rubbing, or if they have vernal catarrh, because inflammation can also cause progression of keratoconus. We compared our cohort of VKC versus non-VKC keratoconus, and we found that there were steeper corneas with VKC, and there were more advanced presentations with VKC, which is expected. Coupled with that, there were more sterile infiltrates. So to conclude, keratoconus in children is more advanced, the progression rate is faster, frequent follow-up is required. Cross-linking at presentation should be done. Accelerated cross-linking is efficacious and progression can occur despite cross-linking if they do not stop eye rubbing or if they have acute episodes of vernal catarrh. Future insights are that the cross-linking protocols need to be developed for adolescent eyes. They may not be same as that for adults. They need to be standardized. The biomechanics, healing response, immunological aspects are different, which values we have for the adults, but not so much for the children. And we require lifetime results for them because we are dealing with them at a very young age. Of course, redos is a reality with children, but how it has to be done, what time and how many times can we do it, that remains a question which needs to be answered in future. So thank you very much for your kind attention.
This is excellent study because this is an extremely challenging situation. First is detection, and many of these patients, they are associated with vernal catarrh also. But
Yes.
I think whatever guidelines and grade 4 where you did keratoplasty, they were different, entirely different group where
Yes.
it was very, very advanced.
Yes, sir.
But you said 80% of the children where C3R was done.
Was done,
It
were-
was halted or I think
Progression was
was stopped.
stopped, yes, sir.
So they have to be followed for long
Yes,
period
sir.
of time.
They have to be followed up long for redos, and those with the keratoplasty, of course, have.
Yeah, surely. Thank you so much.
Thank you, sir.
Now we have the last speaker of the day, Dr. Deepthi. She will be speaking on prescribing glasses to the children. Not a child's play. Actually, it is extremely difficult for children to first do the refraction and then what glasses to be prescribed, particularly younger children. It is not so easy as for adult. And not every optometrist,
Can
they are not. Sometimes we may have trust that, oh, okay, this person will do better job than other.
Thank you, sir. Thank you for that prologue for this topic. So with the corona, more and more children getting hooked to the digital use. I think the children with refractive error are the major chunk of our OPD. And so usually whenever I give this talk, I tell that the glass prescription in children, it's not a children play and it's not just science, there is an art behind it too. In adults, it is just the refractive error which determines how much glass to be prescribed in the children. But in case of children, there are multiple factors. Whether there is an associated strabismus, is it an esotropia, is it an exotropia, what is the age of the child, how much age is left for the metropization, any associated amblyopia, what is the vision at which the child has presented to us. So there are multiple factors which we need to look into before we prescribe glasses in the children. According to the JAPOS, any refractive error on hyperopia of more than 3.5, myopia of more than 1.5, astigmatism, a regular of more than 1.5 or anisometropia of more than 1.5. These are the ones which are considered as the amblyogenic refractive error and they have to be prescribed. But then still it varies between child to child according to the needs and demands. Before prescribing glasses, the most important step is the visual acuity. So assessing the vision is the most difficult step in any child when it presents to the OPD. In a non or pre-verbal child, right from optokinetic drum to flag, the most commonly one used will be preferential looking test or the Teller's acuity chart. To the LIA symbols, the K charts, the HOTV, the Snellen. So it extends from and to the actual Snellen. And nowadays with the children learning alphabets early, we think we shift them to LIA symbol the HOTV charts quite early, and it does give us a exact visual acuity of the child. Once we get the visual acuity, the next step would be to go for the refraction. Remember, in case of children, they have a very strong accommodation. A thorough cycloplegic refraction is mandatory to get the total refractive error which the child is actually having. So in the cycloplegic refraction, it does range from atropinization, home atropine, cyclopentolate to tropicamide. Tropicamide doesn't have any cycloplegic effect, but then atropine is most commonly used in the younger child of less than 4 to 5, and most commonly when we see a child associated with esotropia, that is when an atropine is being used. If in the school, like now when the school is actually going on and if the child does come to us for a refraction, it is tough to put a homide or the atropine because it renders them, gives them a blur near vision for a period of 1 to 2 weeks. In those cases, a cyclopent refraction can be used where within 10 minutes apart, we use cyclopent, tropicamide, cyclopent, which is known as CTC refraction, and the refraction can be done on the same day and the glasses can be prescribed. Followed by which the best way to assess refraction in any child would be using a retinoscope, which is mandatory when you prescribe glasses in a child to learn retinoscope before prescribing the glasses. Nowadays, we do have handheld automated refractometers as well as our regular AR machines can be used if at all the retinoscope is not available. The next step comes is to prescribe the glasses. Now that we know what is the refractive error, how much do we prescribe? So if it is hypermetropia, what depends how much we prescribe is what is the status of the child with respect to the alignment. Is the child ortho, is the child iso or exo? So if the child is ortho, most probably a subjective refraction if you are able to do, then we do a fogging. We give the highest plus with which the child has the best vision. Remember here the goal is vision because the child is already being straight in our OPD. But if the child is having esotropia, what we call as refractive accommodative esotropia, where because of hypermetropia, there is an increased accommodation, increased convergence, and that resulting in ESO. In those cases, we basically give them full correction. So we just deduce the cycloplegic value of the cycloplegic agent and give full-time glasses. Here, it doesn't matter what the child is with that number. The child may still be 6/18 or 6/12. But yet, if the child is perfectly straight, the goal here remains alignment and not the vision. So making the child straight becomes the priority in this situation. Reassess the child after about 2 months. If the child is perfectly straight, well, bang on. It is a refractive accommodative ET, continue the glasses. But if the child is still having a small residual ET for distance and near, then it means it is a partially accommodative ET. That extra amount of the ET has to be tackled by a surgery. But if the child is ortho for distance and more ET for near, that is what we call as high AC by A ratio. Shift the child from the normal glasses to the bifocals, specifically bisecting the pupil. So now coming to myopia. Now the thing is less than 1 diopter. It is basically, there are children of minus 0.75 diopters per who have come to my OPD and told the blackboard is blur and they are not comfortable. So if it is less than 1, it is individualize the child and do prescribe the glasses, but more than 1 to 1.5 do prescribe of the glasses. The most common way in which we prescribe for myopia, it is opposite of hypermetropia. The least amount of myopic number which the child reads 6/6 is what we usually prescribe. But then remember, there are certain situations like if the child is having intermittent exotropias with good control, good to moderate, or residual intermittent exotropia after surgical correction, in those cases we do tend to overcorrect myopia to control exotropias too. And now with children hooking into the mobiles for such a long period of time, cycloplegic refraction is mandatory in all children of myopia to rule out pseudomyopias in the OPD. And never forget retina evaluation. Children as less than as minus 4 diopters per have been noted to have lattices in the periphery, which can be disastrous to the child in their later follow-ups. So progressive myopias, multiple ways are available to tackle. The two most common ones used are low dose atropine, and now the DIMS glasses have been used. That is beyond the topic of beyond this topic. Among astigmatism, the most common thought process was undercorrect astigmats, but now we do correct them fully, give them 6/6 vision with whatever the highest number of astigmatic glasses which they are using. Like in myopes, you ruled out fundus abnormality, rule out ectasia. Ma'am has already adequately stressed pediatric keratoconus is a highly missed entity in astigmatisms. Anisometropia, give off the full correction. This is a difference between the children and the adults. In anisometropes, children do tolerate larger amount of anisometropia as compared to that of the adults. So, and in addition to that, amblyopia management is mandatory. Children with special needs, they have accommodative lag. Push the plus, prescribe the plus. It does help them with physiotherapy activities also. Now I told you, this is my last slide. It is not just science, art it's a art of glass prescription. There are kids who are roaming around with tilted glasses, scratches on the glasses, mother just making the child wear the glasses during the school hours. So these are some things which we need to counsel the parents, that it's not just what the number of the glasses, but how the glasses are worn and how it is maintained is equally important in case of the child. So finally, age appropriate vision assessment, followed by that a refraction. Give a squint based correction whether it is hypermetropia or myopia, and keep on monitoring the child for future squint and amblyopia, and let's make them see this world better should be our motto. Thank you.
I think very nice, very nice. This is very nice topic. Actually, we are due to shortage of time, and time is over. So, but this is an extremely important topic,
Thank you, sir.
because most important thing is that in children it is very difficult to what
Prescribe.
first is refraction, then prescription. It is very challenging. Thank you so much.
Thank you, sir. Thank you.
And one thing I would just say, like you said, the use of AR in children, but I would still say as manual retinoscopy, if you're
Nobody-
good in, nobody can replace a
Retinoscope,
manual
100%, 100%.
Especially for children, because I've had seen my own optometrist in post-traumatic cases. We'll get a lot of post-traumatic scarred children,
Correct.
babies. Okay, and according to that, the vision was only 2/60. Now I've done his scleral fixation. He was operated by my senior resident during emergency hours. Now I've done a scleral fixation for that child, and he's 6'9" now. And
True.
according to them, that time he was only 2/60 with their aphakic correction. So if I'd left the child at that moment thinking that my refractionist has done it right, you cannot just trust your refractionist also. Sometimes
100%.
you have to take over in those cases.
No, I think with the pediatric OPD, no
I
matter
think
what.
sometime we doubt, we may have 4 or 5 optometrists, but then we will say, okay, this person, sometime, not all the time, but sometime, that okay, children refraction, this person will do better. Very nice presentation.
Thank
you
you.
so much.
Thank you, sir.
With this, we come to the end of the session. I am thankful to Dr. Venita Gupta because actually I was stuck up in that OPL. I was one of the judges there, so that's why I was late. But we are also thankful to all the presenter, Dr. Rohit Saxena, Dr. Deepti, Dr. Namrata Sharma, Dr. Amit Raj.
Can we have a quick photograph?
Yeah, thank you so much. And audience, because I think probably this hall has the maximum audience.
किसी को दे देते हैं ये कैमरा